Next up, Morgan Honea, our Executive Vice President, and I are going to give a Contexture update focused on the work that we have going on here in Arizona, since that impacts your organizations the most, but certainly also giving you insight into work that we're doing across our organization in Colorado and beyond with other HIE colleagues across the country. Make yourself comfortable. Everyone welcome Morgan Honea, our Executive Vice President and COO. So what we did for this presentation is I put together some slides of what we've got going on, again, throughout Contexture. We usually do this presentation every year at the summit, and when I look back, it's always a good reminder of all the progress we've made over the course of the last 12 months. So really tried to switch it up this year and focus more on some new resources that we have, linking you to information that's out there, because we only have, again, 45 minutes scheduled. We might have a little extra time given starting early, but really just want you to have all the resources and information that you need. A lot of the topics we're going to touch on this morning are also covered throughout the conference, so I will try to cross-reference where they are going to be coming up in the agenda so that you can learn more about all the different initiatives that we have going on. So this morning I'm going to cover the Contexture basics. Morgan and I are going to tag team some of the service updates. I'm going to cover a few. He's going to cover a few. Then Morgan's going to wrap us up by talking about our 2023 to 2025 strategic plan at a very high level. We have more information coming out on that in the coming months. And then also giving a few updates on some national interoperability efforts. So hopefully folks are aware by now that Contexture was created as a new regional organization last July when HealthCurrent and Korea merged together. We are the largest HIE in the Western US, and you can see our geographic area covered here. I think a really, really exciting update in the last month or so is that we went live with our new consolidated website. So throughout the transition, we have been continuing to use the names HealthCurrent and Korea. We had the HealthCurrent and Korea sites because they were so comprehensive. There was so much information on both sites. It took a lot of work to get that all together and move that all over to our new contexture.org. So what I've tried to do throughout today's presentation is really tie to some of the new places on the new website, because there's a ton of information out there. What I really love about the new website is how our different products and services are broken out by category. So you'll see across the bottom of this homepage screenshot that there are 6 different categories of services that we offer: health information exchange, quality improvement, data analytics, social determinants of health, advanced directives, and public health. So those 6 different categories you'll see through the slides this morning is how we've tried to start framing the different services. Now there's a lot of overlap. So we do things in HIE that impact public health. Public health is an HIE participant, but we really do have differentiated services in these different areas that I think it's important to call out as separate. Also on the home page, if you scroll down, you can see a lot of great links to other stories, blogs, news stories. So this insights section is at the bottom of the home page. You can see that there's a note about our board voting to approve an expansion in permitted use, which I'll reference later. You can see enhancing patient care, coordination and reporting through COVID-19 and beyond, our coordinated COVID-19 response in Colorado, and then some of our large-scale metrics in terms of the population that we cover now: 28 million patients, over 10,000 users per month, and over 23 million alerts per month. So a lot of data flowing through our network. We often find our CIO, Deanna, who will be here later today, we often find that when we talk to technology vendors, we are one of the largest networks out there, and so we really do have a fantastic technical team that makes sure that all of these systems are running and keeping up with all the data flowing through them. So in Arizona, we have close to 1,100 participants now. You can see this, what we call the participant wheel, all the different categories of participants. The numbers in each of those categories continues to grow. We are continuing to work to consolidate how we categorize participants and different segments of the healthcare industry, but we also continue to add data sources. So we have over 300 data sources that are contributing data to the HIE, and again, those are Arizona-specific numbers. We have very similar numbers across Colorado as well, so when you add those two together, it gets quite significant. And in Arizona alone, we have data available on over 12 million individuals. One of the things, as I start going through these 6 different categories of services, I'm going to do a few, and then Morgan's going to do a few. The Arizona HIE services, one of the things that's really nice on the website now is if you go under the solutions section under HIE, you can see Arizona HIE and Colorado HIE. We have these really nice HIE service catalogs for each state that goes through, and you can see there in the table of contents the different types of services and how we split out our products and services and categorize them. Everything from our portal to HIE alerts to data reports and extracts to all the different types of bidirectional exchange. And really we continue to have those focused efforts on the integration of physical and behavioral health information, various types of alerts. So it's not just admission, discharge, and transfer notifications. We have alerts that are COVID specific. We have ones that are specific for EMS. We now have mental illness hospitalization alerts. We have ones that are through patient-centered data home, which means based on a zip code, you could be getting data on an admission for one of your patients that's in Nevada or San Diego or Indiana across the country. So there's a lot of variety there. We continue to support bidirectional exchange for a variety of different mechanisms, and you'll see the importance of that when we talk about some of the themes that came out from our strategic plan. And then we have new and different public health reporting options. A lot of work went into advancing a lot of the public health opportunities we had talked about with ADHS and our county public health partners over probably the last 10 years, just in the last 2.5 years during COVID. So again, I've tried to link any of these resources that are available on our website so that you can navigate to these different places on our website and check out our new site. And then there's a Colorado HIE service catalog. So you can see the variety of services that are available for our Colorado participants. Some of the differentiators and unique services in Colorado include EHR results delivery. We do a lot of quality improvement services that we'll talk a little bit about, and a variety of some unique and different public health reporting options and public health services than what we have in Arizona. So again, as we came together as an organization, we're looking at where those unique efforts are, and so that we can advance things for each state in different areas that maybe we haven't been able to do before. In the area of data analytics, again, historically, we've lumped everything together as health information exchange, but we really have done significantly more, especially in the last few years, and thanks to our team members from Colorado, who Kotrys had done a lot more in the space of dashboards and analytics historically. As we brought our teams together, we've been able to advance a lot of these efforts even more and more quickly. There's going to be a session on this at the summit, so I'm not going to spend too much time talking about it, but we are in the process of implementing a new, brand new crisis bed registry for Arizona. We think it's likely the first of its kind throughout the country. It's a partnership between Access, Solari Crisis and Human Services, and Contexture. We're working in partnership with all the REBAs, all the crisis healthcare providers and their facilities. And really the purpose is to track capacity within both inpatient and observation crisis facilities so that there's more general and real-time availability, that when mobile crisis teams and the crisis system is dealing with a crisis situation, they're able to have more real-time access to what beds and availability and capacity is in different facilities. So we will have an enterprise data warehouse For the most part, we're hoping that electronic health records will be able to supply the data that can keep that information up to date in real time. If not, it'll be near real time and as regular as we can get it. And then it'll be a provider-facing dashboard. And we're working to get that system really piloted through a Maricopa County pilot by the end of this year. And then by March of 2024, will be statewide. Again, I don't want to spend too much time talking about this effort because it is something that we've got a whole session on, so please come and you'll hear from, we've got participants from Solari, from Access, from one of the crisis facilities that are going to come and speak to really the vision for this crisis capacity dashboard and really what it will be able to change for the community. Additionally, we have started working on a number of different data dashboards for Access. Access has been really interested in having more transparency around different data metrics. These different data dashboards are run primarily with claims data. In a few instances, there might be other data sources. The first ones we worked on earlier this year were some Access COVID dashboards. So I've just got a couple examples here. This one is showing across service lines and across the state what the different immunization rates were. This is a little bit, it'll be updated on a more regular basis, but the data on this dashboard is from April of this year. And then by race and ethnicity, what the different immunization rates are for the Access population versus the population at large. We've got a series of other Access data dashboards that we will be working on with the agency throughout the rest of the year, and then Access will be determining how those will be rolled out to the community, how they'll be displayed on their websites and through other mechanisms. I threw a couple slides in about this clinical informatics project because this is actually something we just presented on at our national Civitas Networks for Health conference last month. And we had one of the medical directors that had rounded through, or one of the fellows that had rounded through Access, as well as a tribal representative, and myself presented at the Civitas conference. And I've just found it really interesting that this is an example of a project that we did in terms of looking at certain Access population and determining what data is available for diabetes control performance and really looking at hemoglobin A1C levels. What's available that comes through claims data, and how can that information be enhanced through looking at the clinical data that's available through the HIE? So really, they were trying to determine the increase in data that was available using clinical data versus claims data, because a lot of times those levels and those numbers, those clinical data elements aren't necessarily in the claims file, and then trying to assess the difference between 2018, 2019, and 2020 to see how diabetes control varied as we got further into the pandemic. So this was just an example of a project that we were able to do collaboratively because the data we have. Our team worked with the Access team. There was a member list of American Indian Health Plan members from 2018, 2019, and 2020. We queried HIE data for particular data elements. It returned lab values that identified, you can see the bottom note there, that improved data results from lab results from less than 1% using claims data to 10 to 15% using HIE data. Now you might still say that's a pretty low number, 10 to 15%. We still are working to get a lot of the tribal facilities to send clinical data proactively to the HIE because there's a preference with IHS, and this is similar with other federal agencies, to actually do a query response mechanism, which means it's really at the episode, at the point of care that you query for that information and pull it back, which means that we don't necessarily have the full data set on that population. So that's where the benefit and some of the opportunities but also challenges can come into play depending on what type of data exchange you have. And I'm not going to go through the whole presentation, but you can see as some of the different slides that Access put together how certain facilities and tribal facilities that are sending us data are the highest data contributors to this effort. And this is just an interesting slide to see that based on the data that we were able to pull, the increase that those orange is HbA1c greater than 9 and the blue is HbA1c less than 9. So you can see from 2018 to 2019 to 2020, the greater than 9 prevalence did increase, indicating that, with the information we had available, that diabetes control was more challenged during the pandemic as we got further in. All right, I am going to turn it over to Morgan, and he's going to go through a few of our next few services.
Good morning, everyone. I'm a wanderer, but this stage is really creaky, so I'm going to try to stand still. So as you heard Ellen talk a lot about this morning, we not only have the traditional HIE services that Melissa just described, but we also do a lot more. And so one of the areas that I wanted to focus on this morning is our quality improvement program. We have a team of NCQA certified experts that work across our participants on a variety of different programs, including some of the ones that Ellen described. And so we currently are working with the Facilitating Alcohol Screening and Treatment, or the FAST program, the Incentive and Support for Medication-Assisted Treatment for Opioid Disorders. All of these programs that you can see here, we actually have quality improvement experts that come and work side by side, hand in hand, with our participants to help them achieve their milestones and goals across a number of different programs. Next slide, Melissa. Actually, can I just have the clicker?
You may, please.
We also do a lot of quality reporting. So in Colorado specifically, we work very closely with the state Medicaid agency to support ECQM program, which is where, again, our quality improvement team goes out hand in hand with our participants, works with them not only on how do you generate these reports out of my EMR, but also how can we integrate HIE data, as well as how can we improve workflows. See, can you hear me creaking up here? I'm gonna stand still. How can we improve workflows to make sure that when we're entering that data into the EMR, it's actually getting to those places that are going to impact that quality reporting? I would share a personal story. Prior to coming to Contexture, I ran an FQHC in eastern Colorado, which if you've never been to eastern Colorado, it's more like western Kansas. And many of these programs required reporting on things that we didn't do inside our facility. So mammograms is a good one. There was no place in eastern Colorado that provided mammograms. And so anytime that I had to report on services for my quality that were being performed not only outside of my facility, but outside of the entire region, it was really, really challenging. And having the HIE be able to support that type of data integration would have been a great thing to have back in that day. So here we are, 8 years, 10 years later, and we're able to do that for our folks today. So this is a great program that the participants get incentives from the state Medicaid agency to participate in, and then we're able to subsequently support the improvement of their ECQM measures by integrating HIE data and working with them on workflows and technical assistance. If you were able to join us last year, I'm going to focus on 2 other programs that we launched in the summer of last year. The first is the Community Cares program. This is a partnership with Access and Unite Us, focused on providing that closed-loop referral technology solution for CBOs and healthcare providers that are focused on social determinants of health and work. And so again, you heard Ellen talk about, and we had a couple of questions from the United Way or the local Y. How can we make sure that those referrals are getting back out into the community in a way that they can receive them, provide the services, but also that we know that the services are happening and the things that we know that are impacting our patients' lives are actually being followed up on in those CBO types of organizations. So this kick-started last year. We took a little bit of a pause as some of our vendors, the vendor landscape shifted a little bit, but we've just now restarted the program, and if you're interested in this, please find me or anyone on the Contexture team. We can make sure that you have all of the information that you need to be a participant. A really exciting program, and I see Carla out here, that you also heard about last year is our Advanced Directives program. So again, this kick-started last year in the middle of the summer. The Secretary of State database was migrated over to Contexture, and so we took all of those records that were in the Advanced Directive Registry at the Secretary of State and have input them into the new AZHDR platform. And so this is the website. Again, if you want to go out there and look at more information, feel free to. It's right there. But to date, we started with 73,000 advanced directives from the Secretary of State and then transitioned those into the AZHDR platform and have grown that to over 85,000 in the last year. Our goal for this year is to hit 4% of the entire population. Right now we're sitting at about, where'd it go? I know it was on there, 2.3%. So some pretty dramatic growth that we'd like to see in that program, and Carla's sitting right over here. You can always pick her brain and make sure that you know what's going on in this space. Melissa?
All right, thank you. And we actually have sessions on both SDOH and advanced directives throughout the event, so make sure to catch those. And again, our team members from all three that head up all three of those activities that Morgan just went through are here. So I think it's really great to see actually the quality improvement services spun out of the Regional Extension Center grant that COREO had, which that grant in particular holds a special place in my heart as well. So it's really cool to see how that program led into all the quality improvement work that we're able to do in Colorado. Okay, next up we've got public health. So first thing I wanted to note, this is really exciting. We actually had our board of directors in July approve an expansion to our Arizona permitted use policy that expands the ability to use HIE data for public health. And really what it does is it aligns the policy with HIPAA federal regulation. So it really allows the HIE data to be used in alignment with regulation that's already out there. We had actually added public health permitted use prior to the pandemic as a first step for public health investigations, and especially given the expansive work that we've done in this area and that as a community we continue to do in this area as a result of COVID and understanding the importance of public health and our work in that area. We certainly had full support across the community and across our board in level setting and having this expansion to the permitted use policy. So again, you can see more information at the link at the bottom of this slide. If you're interested, it's on our website. We did send a notice out to all participants and more information if you have questions. We also have done a lot within COVID, both related to COVID, but also starting to look at some of the exciting public health initiatives we've been wanting to pursue in Arizona for the last few years and haven't been able to for a variety of reasons. So this is just a reminder that we did provide real-time ADTs throughout the surges in the pandemic to support real-time data flowing to the Arizona surge line. This was pretty unique from what I've heard from our colleagues at ADHS when they talk to their colleagues in other states. They were working off manually submitted data, and we were able to leverage the real-time ADTs that we had flowing for 98% of all the discharges in Arizona to actually have them flow to show bed capacity during the various surges throughout the pandemic. We also did some national COVID-19 dashboards. This was a contract with the Office of the National Coordinator that was awarded to COREO, given the work that our team has done in producing dashboards and being able to track data. We had data flowing in, de-identified data flowing in from over 15 HIEs, I think. Yep. And you can see it's small, but because I was trying to show, we're trying to show here two different snapshots. We did both COVID-19 lab dashboards and immunization dashboards, but you can see in that snapshot of the country that there is data from across multiple states. So we had information flowing from as many HIEs as could participate in that time frame, and really was an exciting project to demonstrate the power of bringing data together, not just within our HIE across Arizona and Colorado, but across multiple HIEs and the work that we all do day in and day out for standardization and normalization. So that was a really exciting project. We also have public health connectivity services. So sometimes we get asked by participants, I've really wanted to utilize the HIE for reporting immunization data. And for a number of years, we were working on completing that connection, making sure it was tested. You can do that today. We have several participants that are taking advantage of that, so you can utilize your connection through the HIE to submit immunization data to ACES. We also have the ability to query ACES and pull data back through into your system. We're supporting e-case reporting. We're working with ADHS to utilize some of the national networks and provide project management support to connect up hospitals and FQHCs for electronic case reporting. And we have done a number of different electronic lab reporting connections throughout the pandemic, and utilizing, again, a connection through the HIE to be the intermediary to facilitate electronic lab data flowing to ADHS. So if you're a participant, if you're interested in those services, just check with your account manager and we can get you more information. And then this is one that I'm really, really excited about. And it's not specific to COVID, but the pandemic, don't let a good crisis pass you by. So we were able to utilize some of the interest and the need for data foundations and data infrastructure to really advance something we've been talking about for over 10 years. I don't think Paula's here today, but Paula Mattingly at ADHS said when she started going back and looking through her notes of when we first started talking about the need for a master patient or master person index at the public health level and the ability to utilize what the HIE had, her notes went back like 13 years. So literally found notes from over a decade ago when we started talking about the need for this. ADHS has tens of different databases, registries, and we've talked about the ability to utilize the Master Person Index at the HIE to provide unique identifiers back that can help link together unique individuals across those registries. And actually, it's not just within one agency. You can see here that the key partners are ADHS and Access in this initiative. So we actually, and again, Korea's historically had done some great work, and we continue to do that work at Contexture in Colorado in bringing together disparate data sources from different programs within different state agencies and reconciling which individuals are the same when there might be individuals that are eligible for a program but aren't enrolled because they just didn't know about it by cross-linking unique ideas across different programs. So this, the Arizona Master Person Index is a planning collaborative that is funded through the STAR grant, which is a federal grant that we received a couple years ago, and we are doing all the planning so that we can be ready to launch into implementation as soon as this process is done. Again, this is just the general data flow where the agency system or registry can send person attributes. We have a whole list of what those attributes are over to Contexture. We use our MPI service to actually link the person attributes to a unique identity, and then that unique ID is returned. We can actually, and we've got some great programs in Colorado for this, we can actually enrich the data with other demographics as it relates to health equity, other things. We return that information back to the agency, and I've got another slide that's not in here, but you can use, linking together somebody who's within, 2 ADHS registries with somebody from an Access member list. And we can start doing that analysis across agencies that the state is very interested in. A few miscellaneous initiatives and updates. Another one that I am really excited about, because we've talked about this for a long time across our community, is the ability to use HIE data for research. So we actually were funded by the NARBA Institute, and in collaboration with ASU, Coppersmith-Brockelman, who's our law firm that provides a lot of the legal analysis for this, we did an entire evaluation over the last year. We did an environmental scan, we did a legal analysis, we did a data and technical scan that looked at the readiness of our data. And this is not the end of the planning, but what was really great is we made some great progress in analyzing what do our stakeholders, what does our community want? What have other HIEs and all-payer claims databases across the country done? And what is their structure? How does governance work? What are the challenges that they have faced? How have they overcome them? The legal scan really diving deep into the legal environment and what's possible today, what could be possible in the future, and then just starting to scratch the surface in terms of the data and technical scan to really look at what data we have in the HIE, how research ready is it, what additional work would we need to do to be able to move some of these initiatives forward. We're probably going to go into a phase 2 of planning for this because there's a lot more detail to figure out before we would be ready to launch any efforts to utilize HIE data for research, but this was an excellent first step, some great work completed, and we're actually wrapping up the project this month, and hopefully we'll be able to share out some of those lessons learned in the coming months. We do have, because I know we have a lot of participants in the audience, I did want to make sure to let you know we will have some upcoming changes to our fee structure. Our board of directors has, for probably the last 5 years, wanted us to explore what our future financial model would be and what type of fee structure would be appropriate for our community going forward. We have been very fortunate to be able to have a fee structure where the majority of our participants do not pay fees, but we want to make sure that there's the right balance and that there is some fee structure that reflects the value of the services with reasonable fees across our participant base, with a few exceptions. So the merger was a great opportunity because the merger already was calling for the development of our financial model and our fee structure for Contexture overall, and we're trying to bring our structures together. And we did have different structures across both Arizona and Colorado. So we are in the process of going through a transition related to the fee structure. For most entities, we will not have fees in place for participants that haven't had fees historically until 2024. So this is going to be a long transition, and we want to make sure to give everybody plenty of notice. The rollout dates for the new fees is January of 2023. Any new participants that join after January will just get started on the new fee structure. Again, this is something that Colorado's had in place for a number of years. It is reasonable. They have hundreds of participants, and the value is there for the services. So we hope it will not be too challenging for our participants, but we certainly welcome feedback as we go through this process. So ACOs that are current participants and new HIE participants starting in January, anyone besides ACOs that is a participant already by the end of this year will not see a new fee structure until January 2024. Also, our board approved for critical access hospitals, rural health clinics, and tribal facilities, similar to a policy we put in place in Colorado earlier this year, will have no fees indefinitely. So really making sure to look at rural Arizona and making sure that our rural colleagues and participants across both states have the support that they need. But I kept the good news after the fee structure. We still have tons of financial incentives that should certainly outweigh any fee structure we should have in place. There's still a very robust differential adjusted payment program in place for HIE participation. For HIE participation in data quality initiatives, anywhere from 1% to 8% of your Medicaid rate. There's also, in addition to that, community cares participation initiatives and incentives anywhere from 0.5% to 2%. Those are additive. They're not one or the other. We have an HIE data supplier program that's a continuation of our HIE onboarding program from the last several years. And so if you didn't receive an incentive for participation in the HIE onboarding program, you can get anywhere from $5,000 to $20,000 one-time payment for submitting data to the HIE. Community cares, CBOs. We heard from a representative from the YMCA about challenges with CBOs and financial incentives there. So we have a CBO incentive program up to $10,000 per organization. It is milestone based, so it depends on how you're utilizing the service and what connectivity you put in place. And then a CBO assistance program up to $5,000 per organization that is cost reimbursed to help support technology needs you may have, some level of staff support to actually be getting the technology you need within your own organization to support participating in that program. And then again, the DAP and the American Indian Medical Home are not incentives we provide out directly, but they are available for HIE participation. Is the American Indian Medical Home for tribal facilities. There is actually a DAP incentive and AIMH program, which is a per member per month dollar amount for care coordination, and levels 3 and 4 do require participation in the HIE for bidirectional exchange. So we are actually very, very fortunate in Arizona. I talked to a lot of colleagues across other states, and I'm not sure that we have found one yet that has as robust of incentives for HIE participation. So please make sure to take advantage of these for your organization if you're not already. I'm not going to spend time on this because it is on our website, but this is a diagram from the DAP policy that shows you how DAP incentives increase over time for different provider types. All right, I'm going to turn it over to Morgan.
All right, I'm going to admit that I always get very nervous when I present this because our chief strategy officer is actually sitting out there and she's the one that did all of this work. And her standard of expertise and work in this area, I can't even come close to. But this should say the 2023 to 2025 Contexture Strategic Plan. First off, I want to say thank you for folks in the room who participated in this process. Kelly spent about 6 months on the ground interviewing over 187 participants, organizations, board members, vendors, trying to get really the entire lay of the landscape in where the HIE industry is going, what all you want us to do as participants, either current or future, and she laid out this incredible strategic plan that's going to take us through the next 3 years. Basically, the themes of what we found from everybody that was interviewed are right here. Keep building out the network, require bidirectional exchange so that there's value of constantly having data come in and distributed through the network. Provide a clear value proposition so that you know what it is, the value of what it is that you're getting from Contexture. Keep participants in their workflow. I mean, we all know how incredibly important this is. We all invest incredible resources in our electronic medical record systems, our care coordination systems, our data analytics systems. We want to keep people in those systems where they are natively working. And then grow and expand the HIE into things like analytics, SDOH, and public health and patient access. So the 3 pillars of our going forward strategic plan are threefold: grow and expand the information exchange network, respond by building a data platform that supports the current and future needs of our participants, and then be prepared, develop a responsive organization. So this is about reinvesting in ourselves, making sure that we've got the best workforce that we possibly can, make sure that we're keeping folks engaged and working on the mission and towards the vision of our organization. But a huge shout out to Kelly Joins, and thank you for everybody who participated in this process. It was really comprehensive, and your feedback was really, really valuable and important in developing this plan. A little bit about what's happening nationally, and then I'm going to bring us home. So I also serve as the CEO of the Consortium for State and Regional Interoperability. This is a group that came together during the pandemic to demonstrate what HIEs can do collectively across the country. The names that you see here are some of the largest HIEs in the US. Contexture, CRISP, which serves Maryland, DC, West Virginia, Connecticut. Sync Health is Iowa and Nebraska. The Indiana Health Information Exchange is obviously Indiana. And Manifest MedX serves the population in California. So collectively, we represent about 80 million lives across the country in a number of different communities. And really our goal is to continue to develop both leadership for the HIE industry, but also to demonstrate what HIEs can do when they come together collectively and bring their collective resources together in things like the response to the COVID pandemic. One of our main initiatives is that we're really pushing for this concept of a health data utility. And in my next slide, when I talk about Civitas, you'll see some of the changes that are happening across multiple industries to really leverage the infrastructure that has been built in these networks to ingest and distribute different types of data that are just as important as that information that's coming out of electronic medical records. It crosses the state, private sector, and academia. One of the things that we saw throughout the pandemic, particularly with public health, is that there has been a lot of infrastructure that has been built to electronically distribute data to public health, but in the midst of the pandemic, it was really, really hard for providers to get that data back on things like who has been tested in my population, have they been immunized, et cetera. And so using the infrastructure that HIEs have built over the last 10 to 15 years to support this type of work is really important. We also are active participants in Civitas Network for Health. Melissa is actually the board chair of this organization, and we've got Anna English here with us today, who's also going to be on the last panel of the day. But even Civitas, which is our national trade association, has made the same types of moves towards this health data utility model. Last year, they announced their merger with the organization that supports RICs and APCDs. And then at this year's national conference came out with an announcement that they've entered into a partnership partnership with Health Language to support the Gravity Project. So really exciting stuff that we're very engaged with nationally. If you go out to the Civitas website, you can ping these links that talk about specific programs and projects that HIEs across the country are doing. A really great resource if you're thinking about like things that you can do in your organization or things that we could do collectively at the state level, how to leverage HIE infrastructure to support that work. I'm gonna close this out on maybe a high note, I don't know. There's also no shortage of federal policy that's coming at us quickly. So the first one, and okay, so I'm gonna admit another thing. So I was very nervous about presenting the strategic plan. I'm just as nervous about talking about federal policy because our in-house counsel is sitting right in front of me, and she certainly is the expert here, but we've got 2 federal policies that we're monitoring very closely. And I know that many of these, or these 2 things are probably going to impact many people in this room. We have developed a wealth of information and knowledge and resource about these 2 federal policies. If you are curious about these, please reach out to us. Don't try to do the research yourself. It's mind-numbing, and we have done a lot of that work for you. But the first is information blocking regulation. We talked about this last year. This has been bubbling for a couple of years now, but this is a CMS-sponsored rule. Annie, I'm looking for you. Rule. What's that? It's an ONC. See, I get nervous like this.
You need like a little thing in your ear, you know, and just shove it in your ear.
Channeling Annie. So this is an ONC rule that requires anybody who is stewarding or managing health information to make it available for folks through these types of agreements. The second one right next to it is called TEFCA, the Trusted Exchange Framework and Common Agreement. This is also an ONC initiative. Neither a rule nor a law. It's an ONC initiative. And essentially what the ONC's goal here is to develop or to further develop a national framework for data sharing. We are partnering with our folks at CSRI to develop an approach that could make this an optionality for folks who want to participate in TEFCA through the HIE. But it also, the way that it works is that the RCE, or the Regional Recognized Coordinating Entity. Yeah. I told you, don't go do your own research on this. It's mind-numbing. The Recognized Coordinating Entity has been awarded to the Sequoia project, and they are managing and onboarding what are called Qualified Health Information Networks, or QHINs. Under each of those QHINs will be participants and sub-participants that you can distribute your data to these QHINs through a number of different mechanisms, and that data will be exchanged nationally. What we've seen is there are a number of different organizations that have already announced their intent to apply as QHINs. Epic is one, Health Gorilla is another, the eHealth Exchange will definitely be one. So if you already participate in one of those networks, then you probably have a lot of this covered, but a lot of folks don't participate in those national networks. We just heard from the folks at Sequoia last Monday. The application program starts next month in October. It'll probably take about 12 to 18 months to go through that onboarding and validation process. So we're not gonna actually see data moving through the TEFCA framework for probably close to 2 years from now. But we'll definitely know more as they get through next month and we understand who is actually going to apply to be this QHIN. If either information blocking or TEFCA is something that you're concerned about or interested in, please know to reach out to us. We can be a great resource. Annie is an expert in this field. Our outside counsel, Mel, from Coppersmith-Brockelman, is a national expert in this field. So please come to us and find those resources here. I told you we were gonna bring you home. So all questions and discussion.
And please, we are happy to take any questions. We've got about 15 minutes left. A few other things just to note. We have a lot more detail to share about the strategic plan and our efforts for next year, for 2023. So keep an eye out. As we get next year's annual plan solidified and we get further into the fall, we'll have some webinars available to share more information about that. I also spoke with someone this morning who was looking to learn everything that we are working on and making sense of all the acronyms. So I know we fly through some of the acronyms. If you have questions about any of them, like RICs, what is a RIC? a regional health improvement collaborative. What's a QuIO, a Quality Improvement Network and Quality Improvement Organization? HIEs, APCDs, which are all payer claims databases. Our national organization, Civitas, is bringing a lot of these different health data organizations together. So you will hear from Anna English, who's from the All Payer Claims Database, Civic, in Colorado. You'll hear from Todd Ragau, who's one of the largest HIEs, if not the largest, in New York State. And we love bringing in outside experts who are from different HIEs and RICs and these different health data organizations, so you can hear what else is going on across the country. So with that, please go ahead with our first question.
Thank you. And this question is directed to Morgan.
Uh-oh.
Don't squeak. It won't be that bad. Morgan, I'm curious in terms of interoperability. For the last 3 years, I've been one of the leaders in the Stewards of Change National Interoperability Collaborative. We were one of the leaders in Gravity. We've got pilots going on in New Jersey and New York State. I'm curious as to whether you have connected up with that organization because it's doing this work all across the country, and if not, I'd be happy to connect you with them.
I have not. I'm looking at Annie to see if that has come up. No. So I've not been connected with that, but I would love to exchange information.
And we did just also, through some of our work in assessing, the future of integrated behavioral health, we were just actually talking about, on a call I was on last week, Stewards of Change and the Interoperability Collaborative. I agree we haven't been historically involved in that effort, but Civitas is actually very involved and is getting more involved with the Gravity Project because so many of the Civitas members across the country are working in the SDOH space and needing to really pilot and implement a lot of the different standards and mechanisms specific to Gravity.
Yeah,
but yeah, we'd love to learn more.
And I would love to, I'll catch you after this is over. I would love to connect you up. I was one of the 5 team leaders for their national SDOH agenda, which we did about 1.5 years ago. And we've got programs going literally all over the country. We just did a program with Pima County here in Arizona.
Awesome.
So I think there's a lot going on, and it would be great to have Contexture connected into that group.
That'd
Absolutely.
be fantastic.